thank you all for joining us. So before we proceed, I would like to say a few introductory remarks about Yetena Weg. So Yetena Weg is registered in Pennsylvania, USA as a non-profit organization, and it's run entirely by volunteer members. So currently we have about 70 active volunteer members spanning across 5 different countries and counting more. The number is growing by the day. So Yetena Weg's project engagements could be divided into 4 major aspects. The first is health promotion, which is usually done through discussion and articles, usually concerning the health of the general public, as well as health policy and its implementation. Our second project or engagement site is community engagement. So this is usually done by organizing blood donation drives, inclusivity trainings, equity projects, and fundraising campaigns. So our third engagement is through mentorship and skill sharing. So our team provides direct mentorship. It could be for soft skill or for career and professional development, with various webinars being organized. And the last is through our CME or continuing medical education sessions, just like this one, along with research and quality improvement projects. So Yetena Weg is more than a digital platform. Our volunteer members actually meet in person and contribute to its engagements. So as you can see from this image, there are pictures showing various of our members organizing blood donation campaigns, inclusivity trainings, sign language trainings. This is also another image showing our volunteer members organizing in donation campaigns. So Yetena Weg also collaborates with ROHA and IMSA for a health article writing competition. So a third round of health article writing competition has been held shortly. So ROHA Medical Campus will usually award travel grants for 2 health article writing competition winners. And Yetena Weg will award pulse oximeters for the top 20 winners and Littmann stethoscope for the top 3 winners. The top 5 winners will also get internship opportunities at ROHA Health and other partner institutions. So on the left is the 2021 article writing competition winner, and on the right is a picture showcasing the prizes that were prepared for the 2022 winners. And this is an image with 2 of our 2023 winners that got the ability to travel abroad to the University of Global Health Equity. So Yetena Weg also collaborates with ROHA in the Yetena Weg ROHA Research Fellowship. So this was done along with Tukurambassa Specialized Hospital and St. Paul Hospital Millennium Medical College. So the one that was organized with Black Line started on March 14th. So 3 departments in total participated in this: oncology, radiology, and internal medicine. So research grants were awarded for 4 winners, and mentorships were also given for 10 of the top winners. So Yetena Weg also, in collaboration with ROHA, organized other research medical college. So the difference from Black Line is they prepared for medical students, particularly interns, and research grants were announced for 4 winners. The winners have already been announced. So these are the winners from Tukurambassa Specialized Hospital. As you can see from this image, there were 2 residents from internal medicine, a resident from oncology, and another resident from radiology. This is also an image showcasing the winners of the St. Paul cohort. Okay, so I would like to come to our team, our CME team. As you can see from this image, this is another image showcasing our various CME sessions held throughout the year. So our CME is freely accessible. So for this, Yetena Weg partners with Ethiopian Medical Association, the Ethiopian Society of Cardiac Professionals, Ethiopian Society of Internal Medicine to provide continued training for healthcare professionals. So we've had 9 CME webinars so far for the year 2024. Our average webinar attendee ranges from 150 to 200. So in 2024 alone, we've planned to conduct 30 webinars focusing on emergency surgical and medical cases, ENT, such as this one, Pediatrics, OBGYN, and more. So we invite renowned local and international speakers. So you can access our previous CME sessions on our Yetena Weg YouTube channel, which will be updated regularly. So you can get updates about our upcoming CMEs by joining our Yetena Weg Telegram channel for healthcare professionals. The link will be posted shortly in the chat box, or you can follow our social media posts. It could be Twitter, Facebook, LinkedIn, or Instagram, whichever you find convenient. So To get the best experience in the webinar, we ask that you send your questions to the Q&A or to the chat box. And at the end of the webinar, your questions will be addressed by the guest speakers accordingly. So in order to get CU certificates, you must be able to fulfill the following. You must be able to attend the whole session virtually. The minutes attended will be checked by the Zoom attendee reports. You must fill the Google form for personal details and attendance. So I would like to reiterate here, please fill correct email as well as full name with title, since it's going to be written on your certificate. And you must be able to score 50% and above on the post-webinar quiz. So you'll get your result right away, but the certificate will take 1 up to 2 weeks to be delivered to your email. So we ask that you wait patiently while the certificates are being issued. So this is all. So I would like to introduce our guest speaker today. Our guest speaker today is Dr. Wale Limeneh. Dr. Wale is a highly accomplished ENT surgeon with a strong dedication to providing exceptional health care. He completed his specialty training at Tukur Ambassa Specialized Hospital in 2018, acquiring a comprehensive foundation in the field of otolaryngology. So Dr. Wale subsequently pursued his specialty training in Pediatrics ENT at the renowned University of Cape Town in South Africa in 2019, further enhancing his expertise in the treatment of pediatric patients. So throughout his career, Dr. Wale has demonstrated a commitment to excellence, earning him recognition and accolades. In 2022, he was honored with the prestigious International Scholarship Award from the American Academy of Otolaryngology, a testament to his outstanding contribution and dedication to advancing the field. Currently, Dr. Wale serves as a valued ENT surgeon at St. Paul Hospital in Addis Ababa, where he provides compassionate and comprehensive care to his patients. Additionally, also a co-founder of an upcoming ENT center that aims to deliver quality ENT service to the community. So with that said, I would like to directly proceed to Dr. Wale. Dr. Wale, please proceed.
Okay, thank you, Yetenaweg and Dr. Isra. I'm so thankful and feel honorable presenting this webinar on this day. And I'm sorry for the inconvenience, and I think I'm late to join you. So welcome everyone here. I hope you are seeing my screen here. For discussing about this apparatus, it goes through like the anatomy of the airway. So the airway way means that it's just another passage which just starts from the nasal airway to the level of vocal cords. It's the upper airway, and it's literally we understand like in such a way, and it continues as the trachea and the bronchus and the lung tissue as this is the whole airway. So it includes the nasal cavities or cavity, the pharynx, and the larynx. So each anatomic region is further divided into, let's say, the pharynx is also divided into the nasopharynx or pharynx and the hypopharynx. The larynx has also its own anatomic subdivisions. So supraglottis, glottis, and subglottis. This is a picture of our airway. So airway starts from the nasal and the oral cavity. So from the opening of the nose and from the opening of the mouth, it goes down to the nasopharynx and then oropharynx, and it continues as a hypopharynx. And these are also the upper airway anatomy portions, and it continues
Excuse me, doctor.
as larynx and the trachea, and down to the lower airway parts. So there is
Dr. Wale.
really a difference between an adult and pediatrics airway. Today we're dealing about the pediatrics upper airway obstructive conditions. So compared with adult larynx, the infant larynx it usually lies high in the neck, and okay, so the infant larynx lies high in the neck, and usually the subglottis is the narrowest segment of the upper airway structure. So it's in infants and the pediatrics groups, it's very soft and very delicate structure and very compressible. So you can imagine, if we have like some certain lesions, it's easily compressible. It's very soft, and because of its narrow diameter, some lesions may give a trouble time to the pediatrics age group section, including the nasal, the oropharyngeal, upper obstructive conditions. Like we can mention the congenital ones, including the vascular malformations, the choanal atresia, the macroglossia, glossoptosis, teratoma, the piriform aperture stenosis, and the glioma, and other like encephalocele or meningoencephalocele could be some of the upper airways, the nasal conditions that will give upper air obstruction. Whereas when we see the acquired causes, including the adenotonsillar hypertrophy, the rhinosinusitis, the larynx angina from the infectious origins in the foreign bodies, as well as septal deviation from the nasal trauma or from other causes, it will still bring a problem to upper air obstruction, and some of the infectious conditions, including the throatopharyngeal abscess and infectious mononucleosis, will give also upper air obstructive conditions. So other like causes of the laryngeal problems that will give upper obstruction. Still, we can classify into congenital ones and acquired ones. Among the congenital problems, we can mention like laryngomalacia, vocal cord palsy, laryngeal cystus, and the laryngeal webs, as well as laryngeal stenosis and laryngeal clefts. So we can still have the acquired ones, including the croup, the respiratory papilloma, usually a problem which occurs in young and pediatrics age groups. We call it a juvenile type of respiratory papilloma, and also common problems, including intubation granuloma that will follow after certain procedures or instrumentation or for other surgical conditions. There might happen intubation granuloma, and which may lead to upper obstructive conditions. And other inflammatory condition, including the angioedema, and also the vascular conditions like a hemangioma will also give laryngeal cause for upper air obstruction. Other airway obstructive conditions we can still mention down to the trachea. We know that trachea is a part of lower airway obstruction, but still we entertain as part of a continuation from the upper airway obstruction. A part of the trachea may still be considered into upper airway obstructive problems like tracheal stenosis, vascular slings, tracheomalacia, trapped first ring, as well as the hemangioma, will also be a cause for tracheal problems from the congenital ones. And acquired tracheal problems may be like post-intubation or instrumentation from different procedures can lead to a tracheal stenosis, and this may give a patient to various level of obstruction and various or depending on the severity of the obstruction, there are certain symptoms, and definitely the patient may also go into respiratory failure. And some certain like infectious conditions, including like tracheitis and also neck masses from compressive effect, may also cause tracheal obstructive conditions. And other mediastinal problems, including mediastinal tumors, which may compress lungs or which may compress upper air obstruction structures, will lead to also tracheal obstructive conditions. Like bronchogenic tumors are also quite common to cause such mediastinal tumors, or lymphadenopathies, which may also compress the airway anatomy or may compress the nerve supply, like recurrent laryngeal nerve, and may cause problems. And the lymphovascular malformations, including lymphatic malformations like cystic hygroma, may cause also these compressive factors to the airway. Among the upper obstructive conditions from the nasal structure, commonly we are very familiar to this choanal atresia. So especially in bilateral type of choanal atresia, usually in a newborn life, the neonates may go into respiratory distress, and it is usually an emergency condition, and we may need to secure the airway for life. Especially in bilateral presentations, this choanal atresia should be addressed as soon as possible, and after resuscitating the babies with other oral airway devices or other supplementary conditions. And with choanal atresia, this is endoscopic view from the palatal side. We can see here choanal atresia kids. As we see on endoscopic view, there is a bilateral choanal atresia. Completely, the posterior nasal cavity is closed. Definitely, such newborns will go into respiratory distress and should be addressed as soon as the baby in the delivery room. In unilateral cases, still the baby may adapt the breathing well, or sometimes they may go into difficulty of breathing, or they may go into distress. In such cases, we may have to act accordingly with the neonate's presentation. But in bilateral case, mostly it's a distressful condition after stabilizing and with supplies, including oxygen and devices to open the mouth, as they are very forced or they are obligate nasal breathers. We have to make sure the units are just go into smooth with resuscitation. So this is a CT scan of the choanal atresia, which shows the complete closure of the one side, almost both sides. One is almost stenosed, and the other is there's a bony atresia of the posterior nasal cavity. So usually there are certain presenting conditions in a child who has upper obstruction. So most of the patients who have the upper obstruction, they will have stridor. So this stridor is a common symptom, and it's not a diagnosis actually. It just entertains many diagnoses, and it's a common presentation for most of airway presenting conditions. So this stridor occurs when air passes through a narrowed airway. The airway may be narrowed because of a lot of airway diseases. This airway narrowing will give the different sound quality breathing situations. So we usually have to follow certain protocols and criteria to examine and to take a history, and we have to meticulously take a proper history, and we have to meticulously do a proper physical examination and certain other additional like tests or examination things may be also required. So the history usually may give us it's like a very important clue to the pathology. So if a proper history is taken and the proper examination is done, it may lead to pinpoint the diagnosis. So most of the time, in such cases with airway obstruction, most of our diagnosis are dependent on recently already with the technology. We have like flexible endoscopy, we have rigid endoscopy, and also the imagings like a CT scan or MRI. Depending on our enumerated diagnosis, we can choose our mode of investigations or imaging modalities. So in such management ways or in such presentations, we usually have a team approach, and the proper equipment should be there. And sometimes we have to expect also the patients may go into rapid deterioration depending on the condition of the pathology. So it may be worse in units and younger children, as they do have like a very narrow airway anatomy. Like an edema to this narrowed airway may give a severe obstruction to the airway, and there may be a significant compromise in the airway or in the ventilation. So across the length of the airway, starting from the nasal to the oropharynx and then the larynx, there are different sounds that we entertain from the breathing obstruction. So let's say from the nasal cavity, usually they do have a stuttering noise breathing, and their voice usually will be muffled, and their cough typically it is absent. And on a supraglottis, they usually they will have a stridor, which is happening usually on respiratory phase, and also on their voice they do have like a hoarse or glottic breathing quality, and usually the cough will be barking type. Where the obstruction is a subglottic area or region, usually the airway will be stridor, which is happening in both phases of breathing, like inspiratory and expiratory phases, and their voice will be usually unchanged, and usually they do have a brassy cough. When the obstruction is lower airways, usually they will have expiratory stridor, whereas their voice will be unchanged, and usually they will have like weight sounding or like washing machine sounds. When we listen with our um, ears, we will listen washing machine sound. So, in a patient or in a child who has presented with any stridor, uh, we have to take certain inclusive stories like tracheostomy dependency, or if there is any failure of extubation, if there is like a longer duration or shorter duration. These are very important history pointers, and also the previous intubation history, and also temporal relationship, as well as the effect on exertion or feeding chance are very important things that we have to check on our history. And the intubation history, let's say if a child was there in ICU for different medical conditions or surgical conditions, that's very important thing is we have to know the length of the hospital or the ICU stay, and it may give us a very important clue for upper airway obstructive conditions. And also any previous history of airway surgery may be linked to the current presentation of a child. So these are very important points that we have to focus on, taking a history from the child who has presented with upper airway obstruction. So other additional history should be also seeked about perinatal history, like if there is like obstructed liver or other linked or other important perinatal history should be mentioned during our evaluation of a child with striders presentation. So in the pattern of stridor with position, like feeding, sleep condition, and the stridor in regarding with the excitement of a child or an excitement of a baby, and also the connection with crying, or when the child gets upset or when the newborn gets upset. If there is a change in a stridor, if there is a change in the breathing condition, we have to also observe these situations, and we have to pinpoint our diagnosis. And certain associated features like dyspnea, tachypneas, and also dying spells, as well as nasal frying and head bobbing, maybe they are depending on the severity of obstruction. And also sometimes the child may also present with cough and also the wheeze. And the other general medical conditions may also be important for the current presentation of the child who has presented with airway problems. On examination, we have to observe a child. Any child who has presented with airway obstructive conditions should be observed for voice quality, for presence of cough or absence of cough, and if there is any wheeze. These are usually, the localizing clinical conditions, or these important clinical conditions will give us to reach to a certain diagnosis. And the others, like effects of obstruction, like chest recession or use of accessory muscles or respiratory muscle use or exertion, also will give us an important clue how severe the obstruction is, and also it may give us also some localizing conditions. And the stridor, the timing, especially if it happens on an inspiratory phase, if it happens on expiratory phase, if it happens on a biphasic way, it gives us a clue to pinpoint still the problems. And also, like non-laryngeal causes, including adenotonsillar hypertrophy, and if there is a tongue falling or glossotosis, and also if there is like a big tongue like macroglossia, These are also that we have to look for a patient who has presented with airway obstruction. On imaging, usually we may need to take like plain films, like lateral projections or AP projections may give us different airway anatomic problems or functional problems may be entertained with such plain films. And also the advanced imagings, including conventional like the CT or a MRI, may also give us an important clue to airway anatomy, and airway obstructive conditions may be entertained with such imaging modalities. And the fluoroscopy tests also may help us to assess also swallowing as well as airway dynamics. So we may get important clue about this airway as well as digestive tract with the fluoroscopic studies. The advantage with the endoscopy also highlights the airway evaluation and airway management. One of the commonly that we use as an NT is a flexible nasopharyngoscopy. This flexible nasopharyngoscopy usually helps to assess the nasal passage, the nasopharynx or pharynx, and the supraglottis, as well as the glottic airway will be examined, and we may get a detail about this certain structures on these areas. With this endoscopic evaluation, we can see still we can confirm the choanal atresia, or if there is a choanal stenosis, we can still can get an information about the hypertrophy of the adenoid, and we can still size, or we can give it can give us size of the hypertrophy, and the obstruction level can be also entertained with this simple endoscopic test or examination. Laryngomalacia can be also entertained with endoscopic evaluation at OPD with the patient still awake. And the most important thing that we usually need a flexible endoscopic examination is vocal cord mobility. Vocal cord mobility is still the patient will be kept awake, and with endoscopic examination, still the vocal cords can be entertained. Subglottic lesions, we know that further airway evaluation may need examination under anesthesia, but still at OPD or with the patient awake, we can have an information about the rigid endoscopic or John Hopkins Road telescope that will give a proper airway evaluation. At the same time, it can give us an access to airway intubation. Once the child is put on under general anesthesia and the proper ventilation maintenance, still we can have a detailed information about the supralaryngeal structures, laryngeal structures, and the distal airway secrete, the trachea and the bronchus. It's very, very helpful, and we are now practicing it right and left, and definitely help us in managing as well as in diagnosing certain conditions. We will see the common upper obstructive disease, especially in children. The most common one that we usually entertain is laryngomalacia. The laryngomalacia, the pathophysiology is not well understood, but still there is a partial or complete collapse of the supraglottic structures on inspiratory phase, and this structural collapse will give a different level of obstruction to the airway, and it may be even a noisy breathing that will bother the parents, and the airway obstruction condition. It depends on still many factors. This is the most common congenital cause in neonatal or in infants who are presented with stridor. The pathophysiology usually it's thought to be anatomic abnormalities that are observed, the epiglottis will be omega shaped, that is a long and curled epiglottis and a very soft epiglottis. And usually the epiglottic folds are not are short and tightly rounded, and this epiglottic length is very short, and it will pull the epiglottis to the posterior. So the redundant mucosal tissue will be there, and as well as some mucosal will be still redundant, and there will be this mucosal redundancy over the epiglottic folds, and usually the epiglottis will be tall and narrow supraglottis with a deep intra-aortic cleft will be there. And other pathophysiology that is theoretically put is there is an associated neuromuscular immaturity. And there are still certain issues about this neuromuscular involvement. Usually we may need still to do most of the time. 90% of cases it's a spontaneously resolving condition, but in certain cases, in 3 to 4% of or lower percent of cases, they may need interventions like supraglottoplasty. What we usually do is we will release these shorter epiglottic folds, and redundant mucosa will be trimmed out. Patients will have various course of improvement after the surgical intervention, and we don't usually do this supraglottoplasty, but in certain cases, in the lower a few cases, we may need this supraglottoplasty, and it's a very simple surgery that releases the shorter epiglottic folds, and sometimes even the mucosa over the retinoid, including the cartilage, may need to be even removed depending on the severity of the obstruction. So other pathologies from the congenitals, we can still mention like laryngeal cystis, which are very rare. Also, there may be like congenital problems or acquired ones. So usually there is a respiratory failure in infant and young children. On a laryngocele, we mean that usually it's an air-filled dilation of the laryngeal ventricle, and typically becomes worse on breathing, especially on crying. This is a pouch which may be seen, especially on the lateral side of the neck, over the upper area. So we may see this laryngocele. So this laryngocele, it has a communication with the larynx, and it's an air-filled cavity, and sometimes it may fill with the infectious conditions like pus collection, or we call laryngopyocele. And the sacral cyst, difference between these two pathologies is usually in the sacral cyst there is no an opening or a connection to the larynx, and it usually it's filled with mucus. So marsupialization will be crucial to alleviate the obstruction with certain presentations. So this is a case of a sacral cyst on the left side of the larynx. So this is after marsupialization. Imagine you can see here the airway obstruction. So the larynx is almost collapsing, and before the operation, and you can see after the operation it has been decompressed after marsupialization. So other certain pathologies are laryngeal webs. So these laryngeal webs usually, the problem is there is no proper canalization of the larynx, and rarely it happens usually with a glottis region, but rarely it happens to supraglottic structure. And there may be varying degree of obstruction dysphonia depending on the level of the webbing. So usually children with this laryngeal web, they will present with weak and high-pitched squeaky voice, and usually they do have inspiratory structure, and majority they do have anterior glottic webs. So these glottic webs maybe involving the down airway anatomy, including the subglottis region, may be involved in this waving formation. Usually, posteriorly it's very thin, and anteriorly it's very thick, which may fuse with a cricoid cartilage. So, management of such cases usually just releasing this membrane in the middle, and subsequent dilation with different mechanism of dilating the membrane will be very important. And trimming this mucosa, preserving the vocal cord functioning is very important. So the other extending to the subglottic region, the thick ones may require the reconstruction. So the reconstruction involves the larynx and the trachea, and there may be a need for intubation, especially for brief dies like 2, 3, 5 dies. Intubation may be needed to keep healing the mucosa after release and dilation. So we may also use acute placement, and covering tracheostomy may be needed depending on the cases. The other is this subglottis stenosis, which is a congenital one. Due to this defective canalage of the crico cartilage and/or a conus elasticus, um, there is a thickening of this crico cartilage. So usually the shape will be a boat-shaped crico cartilage, and it is very small, elliptical shape, and excessive submucosal soft tissue will be there, and we call it sailing boat shape. Usually this will give a patient various degree, various severity of obstruction. Depending on the stenosis level, there may be different presentations. So most of the who have congenital subglottic stenosis, they may present repeated chest infections. Such cases should be managed and in a proper way. If there is a severe obstruction, there may be a need for surgical intervention. So usually an anterior fusion of the vocal cords will be there in association with the congenital subglottic stenosis. So this is a picture of subglottic stenosis. You can see here it's a boat-shaped structure. Below the vocal cords level, you can see there is a cricoid laminal thickening. So you can see posteriorly the keyhole airway, and this is the typical presentation for subglottic stenosis. And such cases, especially during routine cases like surgical presentations, will a difficulty to intubate such patients. So we have to entertain subglottic stenosis in a child who has presented with recurrent chest infections or recurrent group attacks, or if there is a difficulty during or for other surgical conditions. If there is a difficulty to intubate such kids, we have to suspect the congenital subglottic stenosis. The other problem that will cause air obstruction is the vocal cord paralysis. So, second most common congenital problem of the larynx is mostly other coexisting conditions will be there, and a laryngeal ultrasound will help to assess vocal cord functions. And half of cases are usually unilateral, half are bilateral. Mostly the recurrent laryngeal nerve injury, especially during obstructive labor or obstructive delivery, may happen, and also some certain like mediastinal or chest surgeries, including cardiac surgeries, they may end up with nerve injury. So the patients may present with vocal cord paralysis, and sometimes they may present with aspirations despite the airway obstruction. And so mostly the congenital ones are bilateral, and the cause are idiopathic, but it's to be certain to be there will be a delayed maturation in the vagal nuclei, and patients may recover later on in their life, and they may have a prolonged recovery time. The other airway obstructive condition is subglottic hemangioma, gradually worsening respiratory pathways disorder, which may not be there in the first weeks of life, but with a later presentation with this rapid proliferative phase, the child may go into respiratory distress. So such kids usually may have like 1 to 2% will have also an associated cutaneous hemangioma, and 50% of patients with haplotic hemangioma, they will have also cutaneous hemangioma. So we have to diagnose such conditions, especially a child presented with cutaneous hemangioma and subsequent airway issues. We have to be very vigilant on assessing subglottic hemangioma. So usually it's a pleural phase may last like 6 to 12 months, and the evolution will start later on, and sometimes it may take 5 years or 6 years with a gradual improvement in the condition. But still, it's a very obstructive condition, when you see here endoscopic appearance of a subglottic hemangioma, you can see here a red appearance in the subglottic region, and usually, yeah, sometimes it may even involve the whole tracheal or subglottic region, but here we can only see here in the posterior wall of the subglottic region. So treatment depends on various modalities like tracheostomy, usually very needed, and radiotherapy, CO2 ablation, and systemic steroids. And the one which the safest or the good option treatment, the medical management with a propranolol. It gives us a good systemic response to this hemangioma, and the patient may be managed with tracheostomy depending on the airway obstruction level. The other problems, laryngeal cleft, usually stridor may be a feature, and there will be a prolapse of the cleft into the airway. So such kids, especially neonatal life, they may have a problem in feeding. They may have repeated aspirations, and differential diagnosis will be reflexive disorders, or there could be tracheoesophageal fistulas, and neuromuscular incoordination will be there also. So the kids will have like feeding issues most of the time. And there might be also an associated vocal cord paralysis. And there are types of this laryngeal cleft from 1 to 4. This cleft may involve also the down to the trachea. According to the level of the cleft, we will go from level 1 to level 4. So the management also differs from leveling. From level 1, especially if they don't have like significant symptoms from aspiration or other airway compromisation, they may not be need to repair this clefts. But if they do have symptoms, including aspirations or airway distress, this cleft should be repaired. So as you see here, there is a cleft. This is a vocal cord level, and there is a posteriorly the intraretinoid region is already there is a cleft, a visible cleft. So this may need a repair or depending on the patient's presentation. Other pathologies, tracheal stenosis, acquired, they could be acquired ones or congenital tracheal stenosis there. Usually, the congenital ones are less common, and the congenital ones, mostly the complete tracheal rings. Tracheal rings are not complete in a normal way, but there are certain cases who have a complete tracheal rings. So, in such cases, there might be a tracheal stenosis, and there might be a different level of obstruction. Depending on the stenosis, there are different management options, including resection and anastomosis. So this tracheal stenosis could be graded according to Cotter-Mayer classification. So still, as you see here, there is a complete tracheal ring, and depending on the stenosis level, there might be different levels of intervention. The other is tracheomalacia, which is a less common problem actually. If the trachea is very weak and very flimsy, there might be still a collapse of the trachea during expiration, and there might be expiratory stridor. So the bronchomalacia is the other equivalent terminology for which affects the bronchus, like a tracheomalacia, and both conditions may give the child to respiratory distress or respiratory symptoms with obstruction. Other less common problems is vascular slings, especially the aberrant artery courses, including the innominate artery, may compress the airway, and it may give us still upper airway obstruction. So the expiratory one, the stridor, will be there, and the tracheal stenosis will also be formed from these vascular slings across the trachea. And the pulmonary artery sling is also the other common vascular sling abnormalities. In such cases, there may be different levels or various levels of obstruction. So, bronchogenic cystis could be there as mediastinal problems that will give the same obstructive conditions like vascular slings. So the other one, which is a very common clinical presentation, is the recurrent respiratory papillomatosis. This recurrent respiratory papillomatosis it's a very life-threatening problem, disease. One thing, it's very recurrent nature, and the other, there is a papillomatous growth anywhere in the respiratory tract, including the nose or the oropharynx or the larynx or hypopharynx, anywhere in the region of the respiratory tract will be involved by this papillomatous growth. Mostly, we do have like 100 types, more than 100 types of respiratory, the papilloma virus. This respiratory papillomatosis condition usually caused by the human papilloma virus 6 and 11 types, and especially the 11 type will give an aggressive disease, especially if it happens to the children. It's very aggressive disease, it happens again and again, and there may be frequent booking for surgical interventions, and there may be frequent airway obstructive conditions. But still, other like types of the virus, including human papillomavirus 16 and 18, may also really be isolated from the respiratory papilloma typing. So, especially children born to the ladies with active genital warts, they may be still at risk for acquiring this virus. And still, there are stories or theories about the vertical transmission of the virus into the children, but most of the children will not be symptomatic. But still, there are other like supportive or identified clinical exposing conditions, including the immunity or the genetics, may also play a role in disease manifestation of this viral infection. So the usually a chronic cough and paroxysms of choking, recurrent respiratory infections, failure to thrive will be there, and usually, and it happens as a misdiagnosis of bronchitis or cold. If someone has no clue about this respiratory papillomatis, find children who has been missed with condition. So if we have like paroxysmal coughs and chokes, we should be suspicious of this respiratory papillomatis. You cannot see here any vocal cord, the growth, papillomatis growth. You can see bunch of grapes over different levels of obstruction depending on the extension of the disease. So there are different treatment options. Debulking or excision should be there, and there are technology assisted power dividers, and the cold till surgery is the option, and the laser therapy as well as coblation therapy are there. And the advantage of the coblation therapy is it will generate a low heat therapy, and there may be a low heat transmission to the adjacent structures. And other adjuvant therapies are still on trial and also on practice, like antiviral therapies, including cidofovir, and immune modulators like proliferative anti-proliferative drugs like Avastin, also on clinical practice or clinical use. So the antivirals, cidofovir and bevacizumab, or we call it, this is a chemotherapeutic drug, and we usually order this Avastin for good response of a patient with respiratory papillomatis. The next one is epiglotides. We know that epiglotitis is a very serious disease, but thanks to the vaccination era, we're not seeing to the extent. So immunized groups, epiglotitis may be still a problem, which may follow an infection with Haemophilus influenza. But now the vaccine package already decreased this incidence of these epiglotitis. But it's if it happens, it's very toxic, and children usually they will go quickly into respiratory distress, and they usually will have methyl, and there are toxic presentations, including the fever and drooling, organiphagia, and dysphagia will be there. And they usually prefer a sniffing position, we call it, and sitting upright position with neck extending to the optimized airway. And if there is a suspected epiglottitis, we should avoid examining like routine airway or routine throat examination. So they may have like spasms, or they may have airway obstruction, complete airway obstruction. So we have to be careful not to examine pleurotas patients, and we have to rush for management of this case with stabilizing this case. And on examination, especially on X-ray, we will see thumb sign on lateral X-ray, and the epiglottis will be swollen, and it will have its own typical thumb presentation or thumb printing. And croup is the most common clinical condition also in children age groups, especially those who are 6 months and to 3 year old. This is hoarseness and following respiratory tract infections, recent respiratory infections, it may happen. So usually the croup, there is mucosal edema across the airway. It may involve the supraglottis as well as the subglottis, or the distal tracheal lumen may also be involved in this edematous condition. So usually it's still supportive care is very important, and controlling the inflammatory process will be a very important step in managing the croup. So on X-ray, on AP diameter, on AP projection, usually the pencil tip sign, or we call it the tip sign, the steeple sign will give a clue for tracheolaryngeal involvement. So this is a steeple sign or a pencil tip sign on IP X-ray. You can see the narrowing on the subglottis region because of this edema happening in the mucosa. So these are intubation granuloma, especially for certain surgical conditions. If we get a patient post intubation with voice problems or with airway obstruction, we have to suspect this. Here, you can see on the posterior there are nodules growing over the arytenoid region. This is typical for intubation granuloma, intubation trauma. Here is the anterior vocal cord, like a polyp. Also, this may give various level of obstruction. Laryngeal atresia, it's not like to discuss here, but it is very incompatible to life. The main thing here, we're almost finalizing that once we get a child with airway obstruction, we have to think about how to manage, how to proceed with the next step. And once we settle the diagnosis, the next thing is relieving the obstruction. So usually we have to keep in mind that identifying which patients are emergency patients, which patients are cold patients. So usually, depending on the presentation, depending on the severity of obstruction, we may need to supply oxygen. We may humidify the oxygen, or the air, and pharmacotherapy. Certain drugs, including the adrenaline, may be delivered topically to alleviate this airway obstruction. The other important thing is transferring a patient. So we may be and the first person who are managing the presenting airway obstructive child. So either we may be the right person to manage the patient, or we may not be the right person to manage the patient. So in that case, if we're not the right person to manage the airway, we have to transfer to the right child. I mean, what does it mean? The right child means we have to identify, we have to label which for diagnosis or which child is properly assessed, and we have to select within time, and it should be referred to the right people and to the right place by the right form of transport. So always we have to make sure that such airway cases are properly managed on transporting. So in the meantime, we are just achieving the right care for the patient. So these are my presentations. If you have any questions, comments, you're welcome, and I'm happy that um, um, to present this important topic. But I'm so sorry for any inconveniences happened with slide sharing. I'm not sure if you are attending properly. Thank you very much.
Thank you very much, Dr. Wale. So you've managed to cover a very vast topic in a timely area, especially despite the technical difficulties. So once again, thank you very much. So I believe and we can directly proceed to the Q&A session. These are a few of the questions that have been raised so far. So we'll go over them and we'll directly proceed to the quiz. And finally, we'll attempt the quiz together. So the first question reads, what are the potential long-term consequences and complications associated with untreated or recurrent upper airway obstruction in children?
You know, if there is an identified airway obstruction, definitely if we neglect to manage, we can expect the next level of complication. So definitely the patient or the child will be in air hunger condition if the condition is not treated in a time. We're expecting even days, depending on the severity or depending on the pathology, there may not be even time to manage in few days. So yeah, definitely the complications will be the hypoxic conditions. You can imagine what will happen if we are hypoxic. So anything can happen in untreated airway obstruction. And the other complications like failure to thrive, the child may have, for example, there might be long-term obstructive conditions, including laryngeal waves or cyclotic stenosis. They may have always airway compromisation. So in such kids, there might be complications like failure to thrive or cardiopulmonary complications still can be mentioned. And also growth development delays will be there, and other apparent consequences will be there.
So thank you. The second question reads, what are the current recommendations for postoperative care and follow-up of pediatric patients who have undergone surgical intervention for upper airway obstruction?
Um, the current recommendation for postoperative care and the follow-up is usually they should be managed in a proper team way. So everyone who is putting the fingerprinting on managing such patients should have a proper knowledge and a proper skill to manage one thing. The airway is very sensitive, and doing less is more. What does it mean is, if we are manipulating airway too much, it will not tolerate us. So everyone should have a proper knowledge, skill. So there are certain post-operative care protocols. So they may need like anti-inflammatory or steroid therapy. They may need humidification, or they may need some airway positionings. So they should have been followed with certain protocols, and the team should be in a properly trained way. So even the anesthesia management, the pain control, and other airway or oxygen supply, or based on the patient's need, based on the type of surgery, we may have different kinds of management or post-operative care. But the main thing is we have to have a proper knowledge and skill about each.
Thank you. The third question reads, are there any validated scoring systems or clinical prediction tools available to assess the severity and prognosis of pediatric upper airway obstruction?
Yes, there are. For example, there is a scoring system, especially the respiratory papillomatosis. There is a scoring system, and as well as a CROP. Still, there is a scoring system which helps to level the patient, and which helps to manage the patient according to the score value, and also even the subglottic stenosis and the tracheal stenosis, they will have their own scoring value or severity obstruction level. So depending on this score value, our management will also depend on our assessment. So even the clefts, there are types, or we can still say as a score, but still typing or type of cleft. So depending on the score, our management may be different in its score value. So there are certain scores.
Thank you. The fourth question reads, what are the potential effects of chronic upper airway obstruction on sleep quality, on cognitive development, and academic performance in pediatric patients?
the chronic upper obstruction on sleep quality and on a cognitive development and academic performance in pediatric patients. Uh, you know, as a person or as a human being, we need a quality sleep. So, especially in children who have chronic upper ear obstruction from the regions that we discussed, they will have definitely hypoxic insults. You can, this hypoxia will have a systemic effect on our neurocognitive development, on our cardiopulmonary status, and also on our growth and also on our behavior. So if the children don't have quality sleep, definitely they will have impaired cognitive development, as well as they will have also other consequences on cardiovascular anatomy, like pulmonary hypertension or heart failure will be there. So there are certain consequences with later or with immediate effects.
Okay, thank you. The fifth question reads, how does the management of upper airway obstruction in children with neuromuscular disorders, such as muscular dystrophy or spinal muscular atrophy, differ from other etiologies?
Okay. So, in such neuromuscular disorders, it's very it may give us a challenge to manage such cases, but definitely the neuromuscular disorders uh, may not have a good prognosis on spontaneous recovery. So such patients may depend on tracheostomy or other airway securing solutions, like they may be lifelong dependent on supplies or on lifelong dependent on devices. So these neuromuscular problems may give us really medical management challenge. So yeah, definitely from other obstructive conditions, they may have their own challenge in the management from the resource side or from the expertise side, as well as from the parents. So the problem is we can split into the challenge into the resources, the challenge into the parents, the challenge into the physicians.
Okay, thank you. The sixth question reads, what are the specific challenges that are associated with diagnosing and managing upper airway obstruction in infants compared to older children?
Um, okay, so comparing to older children with infants, one thing, the infants, they do have smaller airways, so any pathologic problems that arise in infants, uh, definitely their smaller airway will be very difficult to manage because of their delicate structure. And one thing, they are very fragile, so it may not be yeah, it may even still need special equipments. So the devices or the equipments may still be specific designed to them, and it may not be easy difficult. It may not be easy to find or to manage a setup to manage in such cases. So one thing, their smaller airway, and even the team, especially in our country, it's very difficult to find or to establish a teamwork because of the lack in the education, the lack in training. So definitely it has its own impact in managing the infants, and when we compare to the older children.
Okay, thank you. The seventh question reads, how do we weigh the risks and benefits of surgical intervention versus long-term use of medications in managing chronic upper airway obstruction in children?
Um, uh, the medical managements, still the airway there are various obstructive airway conditions which may need medical treatment, including the hemangioma, and also other conditions like the papilloma, may need like adjuvant medical management, or even this long-term use of, especially the hemangioma. We may depend on, we may put the patient on for a year and above with a propranolol or other steroids. So treating in the long term with a steroid may have its own undesirable effects on the child's growth, or a child's metabolic status, or a systemic condition. So um, um, uh, it has its own challenges as well as undesirable effects on a child, putting in for long-term medical management.
Thank you. So the eighth question reads, is mist helpful? I believe this question is concerning group.
A mist therapy for a crop is thought to be helpful, but still there are thoughts humidification may not help a patient with a crop, but we certainly follow the mist therapy with crop management. So it helps. One thing, soothing the airway is very important. You know, the children with such disease, or with a crop, they will have like this mucosal dryness and mucosal edema, and so misting and soothing the airway is very important, and it's partly helpful, but scientifically there are still doubts. But misting, especially mixed with some pharmacotherapic agents, including the adrenaline humidification, will be very important to manage medically.
Thank you. The ninth question reads, which one of the long list of causes are treated in the ER by intubation?
Uh, of causes which are treated in emergency by intubation. Uh, Still, we like, especially one with what we discussed is most toxic presentation is epiglottitis. So definitely epiglottitis and also croup with a severe presentation, we may need to intubate. But still, in the emergency management will be difficult in such cases. It's better to intubate in a double setup, especially in OR. If we fail to intubate such patients, because the airway will be edematous and it may be difficult to end up with intubation at the emergency room. So the emergency setup may not be have a facility with OR setup. So especially the communication and the transportation are very important here. But still, epiglottitis, a croup, and also a subglottic hemangioma, and even the papilloma patients still need the debridement, but we may able to intubate, or we may not be able to intubate. So depending on the disease, such cases will be intubated.
Thank you. The tenth question reads, what is the reason for postponing surgery for individuals with anemia? And how can the patient's nutritional status be improved within a week?
I think this is more of, uh, for me, it's a medical question, but still, postponing a surgery. Uh, Remember, we are discussing about upper air obstruction. If the upper air obstruction is time giving, like there are certain pathologies like laryngeal webs, subglottic stenosis. It may be acquired or congenital problems, and laryngeal clefts, and also other tracheal stenosis or tracheomalacia. The surgery, immediate surgery may not be needed in such cases, unless there is an acute airway obstruction. We may give time, or we may have time to manage at elective base. Maybe if even we may need the child to grow, even we may need the airway to grow and to mature. So in that case, if there is a nutritional problem, including anemia from the nutritional deficiency, it should be corrected. And one thing, as I said, there are certain even pathologies that need later reconstruction or later surgery for definitive management of the airways. So it depends on still the presentation, or it depends on the how urgent the airway obstruction is.
Okay, thank you. The 11th question reads, will cleft palate and lip have anything to do with upper airway obstruction?
Definitely. I think if we have been missing that, definitely cleft lip and the cleft palate, they may be part of air obstruction. One thing, this cleft lip and the palate, they may have like associated other abnormalities, other aerodigestive problems. So definitely, sometimes even there are syndromes associated with this cleft lip and palate. So one thing, their own, as I said, airway starts from the nose, starts from the oral cavity. So any lesion involving this areas will have its own effect on the airway obstruction or airway problem. So they do have an effect with the airway obstruction.
Thank you. So the last question reads, what would you advise to any medical center health worker who first encounters a distressed patient before referral?
Uh, yeah, anybody who has been in an emergency department and evaluating a patient with respiratory distress child, one thing I advise, this airway presentation should be familiar to any person who is working in an emergency department. And the other thing is, um, we have to label. If the patient is in distress, we have to manage first. We have to follow certain protocols, certain rules. ABCs, or the advanced life should be followed. So the main thing is saving the patient, or life-saving conditions should be prioritized always. So if there is such distressed patient, we have to do emergency preparations, like we have to make sure that all oxygen supplies are available. Just checking the pulse oximetry, the saturation of patients should be monitored, the cardiac monitoring should be there. At the same time, important history should be sought in facilitating the management. The history, quick history, or superficial history should be dictated. Like there may be a patient who aspirated a foreign body. So quick history is also always relevant, and at the same time, we shouldn't neglect the emergency preparations. So all available emergency equipments, all available emergency drugs should be there, and we have to make sure everything is in the right place in the right time. So this is what I can advise in any person who working in emergency department, especially in dealing with airway obstruction.
Okay, fine. Thank you. I believe most of the questions have been addressed. So having said that, we can directly proceed to the post-CME quiz. So the first question reads, which of the following is not part of the upper airway anatomy? A is nose, B oropharynx, C larynx, D trachea, and E none.
So this question, as I discussed in the early introduction, the trachea is part of the lower airway, even though we discussed the common pathologies that are discussed with upper airway obstruction. But by definition, the trachea is part of the lower airway.
Okay, thank you. So the second question reads, inspiratory stridor is a characteristic feature for an airway obstruction to a level of A, nasal obstruction, B, reed supraglottic obstruction, C, tracheal obstruction, and D, subglottic obstruction.
Um, so the stridor, it happens when air passes to the narrow airway. So usually it may the timing or the phase of stridor may give us a clue. So as a supraglottic obstruction, obstructive airway conditions, they usually have inspiratory stridor. So nasal obstruction, it's not a stridor, rather we call it stertorily. It's more of the low sound quality, and the tracheal obstruction usually in the biphasic the stridor will be there, and in subglottic obstruction in tracheal obstruction usually expiratory phase stridor will be there. In subglottic obstruction most of the time the stridor will be happening with inspiration and expiratory time. So supraglottic obstruction will give inspiratory stridor.
Thank you. So the third question reads, which of the following medical conditions is a congenital cause for pediatric upper airway obstruction? A reads recurrent respiratory papilloma, B is laryngeal web, C is intubation laryngeal granuloma, and D is croup.
The recurrent respiratory papilloma is not congenital problem, rather it's an acquired infectious problem. So it's a viral infection of this respiratory tract cells infection, and it's not a congenital one. Laryngeal web, as I said, it is various lengths of the laryngeal wave formation, or if the larynx failed to recanalize during embryogenic development, it will give a pediatrics upper airway obstruction. So the laryngeal wave is a congenital one. The intubation laryngeal granuloma usually it happens following the trauma during intubation for various reasons. The patient or the child may be intubated for surgical condition or for a medical condition. Following this ungentle intubation trauma, there may be granulomatous growth anywhere in the traumatized site of the airway. So that's still an acquired airway problem. And the croup also, it's an infectious pathology. So it's not still a congenital airway problem. So the laryngeal wave is among the congenital pediatrics airway obstructive conditions.
Thank you. So the last question is, which of the following laboratory tests or examination is not helpful for predicting for pediatrics airway evaluation? A reads awake fiber optics laryngoscopy evaluation, B is endoscopy evaluation, C is neck ultrasound, D is CT scan, and E is none.
So during airway evaluation, together with our vital history and examination and the physical examination reports, we do like awake fiber optics laryngoscopic evaluation. So as I said, especially it's very important in getting an information about the nasal anatomy, oropharyngeal anatomy, or pharyngeal anatomy, and laryngeal anatomy. So with this awake examination with the endoscopy, it's very helpful. And the rigid endoscopic evaluation still, if we need, if we're not satisfied, if we're not certain about the awake endoscopic examination, still the patient may be candidate for to undergo rigid endoscopic evaluation. So still we will get detailed anatomic problems of the larynx or the pharynx or distal airway, including the trachea. So rigid endoscopic evaluation is also an important tool to evaluate airway. Neck ultrasound, still especially for certain cases like vocal cord paralysis, still the ultrasound is very helpful. One thing, it will show us a mobility of the vocal cords. If there is like a vocal cord, it's very non-invasive tool to assess or to monitor vocal cord mobility, and as well as to diagnose the pathology from the outset. So still neck ultrasound is very important, and even it's good also to detect other airway obstructive conditions like as we discussed, like mediastinal or neck masses. It's very important to diagnose with ultrasound. And CT scan as well. Its imaging is very important in certain cases. So, especially tracheal stenosis, or there may be some certain congenital or acquired problems. Still, we may depend on a CT scan to reach for certain conclusive conditions.
So thank you. So I believe all of the questions have been addressed. So once again, Dr. Wale, thank you very much. So you managed to go over a vast topic in a relatively short time, despite the interruptions as well. So thank you very much for that. And to our attendees that have joined us, thank you once again. So we would also like to apologize for the inconveniences we faced today. Our team will work diligently not to avoid matters of this sort in our future webinars. So once again, thank you and good night.
Okay. Thank you very much for your patience, and